So I'm going to open up by presenting this paper. And what I've highlighted here is very interesting. The median time to return to play from a new ankle sprain was 3 days. And the median time to return to play following a recurrent ankle sprain was 1 day. Now, to me, this suggests that ankle sprains are regarded as an innocuous injury, that they'll heal expediently and with minimal treatment. It also suggests that they're commonly perceived as simply a peripheral musculoskeletal injury with only local consequences. Now, the position of ankle sprains in the sports medicine injury hierarchy has been nicely articulated by Dr. Patrick McKean when he suggested that ankle sprains are the neglected stepchild of body parts. I'm going to flip out of this presentation very briefly to talk about what happens if you're FC Barcelona and your best player gets an ankle injury. So I've put this infographic together looking at data from the 2010-2011 season. And between August and May, Barcelona played 60 matches. Okay? They played across 3 competitions, okay? The La Liga, Champions League, and Copa del Rey. And these were the number of games played by Barcelona each month. We can see in January and April, they had 9 games in each of those months. So a really, really heavy schedule of matches. What I've put together here is their data from their wins, which are in green, their draws in blue, and their losses in red. So out of 60 games, they won 44, they drew 11, and they lost 5. Interestingly enough, there was only 2 parts of the season where they had 2 consecutive draws. This part of the season here, where they'd already won the league, and the final game of the season was the Champions League final that they won. The other part of the season was this here, where they had 2 consecutive draws. So what happened during that part of the season? Well, that's what happened, okay? The Ballon d'Or, the best player in the world, gets an ankle joint injury. And for anybody who can speak foreign languages, escalofriante means chilling, okay? And we can look at the mechanism of injury. So this is Thomas Ufolusi. We can see a contact mechanism of injury, and we'll talk about that a little bit later on in a classical study published by Anderson and colleagues. So interestingly enough, we'll see from the Champions League injury database run by Jan Ekstrand, Marcus Walden, and Martin Hagland that ankle joint injuries are the 3rd most common injury in professional male soccer. So what happened to Barcelona's results when Messi was injured? Well, they won the first game and they drew the 2 other games. So Messi, for that injury, he was missing for 3 games. But what happened to Barcelona's goal average? So Messi was missing, they scored 1.6 goals per game. And when Messi was playing, they scored 2.6 goals. So what I'm saying here is that a significant injury, such as an ankle sprain, can have consequences in terms of your goal average. Now, I know that's just a little bit of trivia, but if we want to fully understand or appreciate the position of ankle joint sprains in the sports injury medicine hierarchy, I think we need to know a little bit about the epidemiology. So, across Europe, in all these countries, football or soccer is the most commonly played sport or the most popular sport. So, because we're in Denmark, I thought I'd look for some Danish epidemiological studies, but probably felt more compelled to do this because the eminent chair of the session is a senior author on this publication. So these authors aimed to determine the prevalence and incidence of time loss and non-time loss injuries in adolescent Danish soccer. Okay? So this is the flow chart of the study. In total, at the end, they had 438 players, so quite a large sample size. And they were interested in determining the prevalence and incidence of contact or time loss and non-time loss injuries. And they took quite a unique approach. On a weekly basis, each of the players was contacted via text message to determine the presence or absence of a time loss or non-time loss injury, and players were followed up via consultation or telephone call with the researchers where appropriate. So in terms of results, what did they find? Well, there was close to 28,000 hours of player exposure. In terms of the incidence of injuries, we can see that there's a much higher incidence of time loss injuries compared to non-time loss injuries. And then when we look at the prevalence of injuries, what we will see is that the knee and the ankle joint were the two most commonly injured body sites in this cohort of female adolescent soccer players. So how does this data parallel or contrast to the epidemiological data of male professional soccer? And I'm sure people are aware of this seminal paper published in 2011 by Jan Ekstrand, Marcus Waddell, and Martin Hagland. And we can see from the Twitter feed that it was actually the top-cited paper in BJSM in 2013. And I ran a search on Scopus just last week, and it already has 168 citations. So this paper is very well thought of in the literature. So what did they do? Well, they followed a number of teams, 23 teams in total, across 7 consecutive football seasons. So teams from the UK, Portugal, Spain, Italy, France, Belgium, Netherlands, Germany, and Ukraine. So they started off with the 2001-2002 season, and these were the teams that were included. 2002-2003 season, 2003-2004, 2004-2005 season, 2005-2006 season, 2006-2007 season, and then 2007-2008 season. And the maximum number of teams included in any season was 17, with the minimum number of teams included in a season equaling 7. So what did they find in terms of results? Well, there was close to 500,000 hours of training exposure and 91,000 hours of match exposure. 57% of injuries occurred during matches, and 43% of injuries occurred during trainings. And then in terms of injury prevalence, what do we see? Well, we see that the ankle, in conjunction with the hip and groin, was the third most commonly injured body site. So what we can say is that across the most popular sport played in Europe, soccer, that ankle joint injuries are a substantial problem in this sport. So they shouldn't be regarded as the neglected stepchild of body parts, as articulated by Dr. McKean. This is some data from the National Collegiate Athletic Association, and what we have here is the top 5 men's sport. So American football is the most common sport, and we can see that ankle joint injuries are the 4th most common injury in American football, with ankle injuries representing 14% of all injuries incurred. Then soccer, the ankle joint is the 2nd most commonly injured body site, with ankle injuries accounting for 17% of all injuries incurred. In terms of basketball, in men's sport, it's the number 1 ranked injury, the ankle, representing 26% of all injuries incurred. What happens when we flip to NCAA women's sports? Well, for soccer, the ankle joint is the 4th most common injured body site, with ankle injuries representing 17% of all injuries. In basketball, ankle joint is the top-ranked injured body site, with ankle injuries accounting for 24% of injuries, and we have the same percentage prevalence of injuries in volleyball, with the ankle joint being the second most commonly injured body site. So this data parallels with a systematic review and meta-analysis that we published in Sports Medicine in 2014, whereby we reported that the prevalence and incidence of ankle sprains was highest in indoor and court sports, so the likes of volleyball, basketball, and tennis. So I think the importance of the ankle joint was sort of acknowledged in the beauty competitions of the 1930s, where we can see that a heavy emphasis was placed on a sexy or beautiful ankle. Okay? But what do we mean by an ankle sprain? And this was a definition proposed by the Executive Committee of the International Ankle Consortium in a tripartite publication, with the parent publication being in JOSPT and subsequent publications in BJSM and Journal of Athletic Training. So they've defined an ankle injury, an ankle sprain, as an acute traumatic injury to the lateral ligament complex of the ankle joint as a result of excessive inversion of the rear foot or a combined plantar flexion and adduction of the foot. So what we need to do now is have a look at some of the studies that are out there in the literature and determine whether the mechanism of injury described by this group is actually the mechanism of injury that we see during field and court sports. So in terms of mechanism of injury, we can break it down into contact injuries and non-contact injuries. And what I want to do now is perhaps play a couple of ankle joint injuries, and what we're looking for is to try and determine what is the exact mechanism of injury. So, hopefully this will play. Oh. Yep. So we'll let it play through. So just think to yourself or jot down to yourself, what is the mechanism of injury there? Or how would we describe that? Okay. So let's see this one. So Novak Djokovic is going to injure his ankle joint. We know that he won the Melbourne Open, or Australian Open last week. Okay, we'll see it in a little bit slow motion, a bit closer up. In a couple of seconds. But yeah, he plays on. Okay, we'll let it play on because we see it again. Okay, so we can see from a landing position, he comes down, kind of stubs his toe and rolls into inversion. Let's have a look at it there. Okay, so close up. And then we'll have a look at the final one. Here we go. And what you need to do is look at his right ankle. So that's perhaps the typical injury mechanism that we might see in basketball. So when we look at mechanisms of ankle joint injuries, I'm going to discuss a number of different papers. Some video analysis papers, some biomechanical laboratory-based papers, and then a new analysis technique, or relatively new analysis technique called model-based image matching. So if you're interested in understanding the mechanisms of ankle joint injuries, these would be the papers that I would recommend reading. We have a paper by Anderson and colleagues in 2004, a video analysis study. Fong and colleagues, Kristian and colleagues, Gehring and colleagues, Terada et al., laboratory-based biomechanical studies. Then we have Mock and colleagues and Fong and colleagues using this new technique, model-based image matching. So if we have a look at the first study by Anderson and colleagues, it was a combined epidemiological and mechanistic study. So what they did was they gathered epidemiological injury data in the Norwegian top division from the 2000 season, and then from the Icelandic top soccer division from the 1999 season and the 2000 season. And what did they find? Well, they found, in terms of the results, that ankle joint injuries accounted for 15% of all injuries incurred. So we can see that that parallels nicely with the data from Ekstrand and colleagues, where they found a prevalence of 17%. These authors were able to gather video footage on 26 ankle joint injuries that occurred across those 3 seasons. And they found that 14 of the 26 were associated with a tackling mechanism. 4 were associated with a clearing or shooting mechanism. 2 occurred during running, 2 occurred during landing, and then 2 others were ambiguous and they couldn't put a mechanism or distinctive mechanism on that type of injury. So these are some of the video sequences that they reviewed. And what we will see is that this mechanism of injury is exactly the same one that Messi incurred playing against Atletico Madrid. So we have the player in the white strip and a player in a black and white strip. There's a sliding tackle, contact on the inside of the shank. As a result of that contact on the inside of the shank, it causes the ankle joint to roll over into inversion and the player to incur a lateral ankle sprain. This is the second mechanism of injury that they found to be most common in soccer. So we have the player in the white strip, okay, the attacking player. We can see that he's going to cross the ball. There's a slide tackle coming in from the player in the yellow strip. There's contact made between the 2 feet. And here we can see the withdrawal reflex after that contact takes place. So Anderson and colleagues described 2 mechanisms. First, player-to-player contact with impact by an opponent on the medial aspect of the leg, just before or at foot strike, resulting in a laterally directed force, causing the player to land with the ankle in a vulnerable inverted position. And then the second mechanism is a forced plantar flexion, where the injured player hits the opponent's foot when attempting to shoot or clear the ball. So they were the 2 mechanisms of injury described by Anderson and colleagues. And they've put this into graphical or pictorial format very, very nicely. So again, we can see the contact on the medial aspect of the shank rolling into inversion, and then we can see a forced plantar flexion due to contact between the 2 feet. These are the laboratory-based studies. And in all instances, what happened was an athlete was undergoing some type of biomechanical testing in a laboratory, and an accidental or unpredicted or unexpected ankle joint sprain occurred. So I'm going to talk about this one by Kristian and colleagues, published in Journal of Biomechanics. And what they had was a female handball player who was undergoing some analysis of her cutting technique. So they had force plates, they had a motion analysis capture system so that they could look at angular joint or angular rotations, angular accelerations, and they could also look at the kinetic data also. So center of pressure pathway on the force plates, ground reaction forces, and subsequently the calculation of joint moments. And this represents the reconstructed ankle joint kinematics from the injury trials. So during the two cutting trials, the athlete performed them fine, and then on the 3rd cutting trial, the athlete incurred an unexpected or accidental lateral ankle sprain. Here we have the plantar flexion kinematics of the injured trial in black and the uninjured trials in the hashed lines. We have the the position of the rear foot in inversion, and here we have the position of the foot into internal rotation. So 0 represents foot strike with the force plate, and they've put this or described 3 distinctive phases represented in blue, green, and orange. So for the first phase 1, what they noted was that there was an increased inversion and internal rotation position in the injured trials compared to the non-injured trials. So 14 degrees versus 6 degrees and 5 degrees for the non-injured trials, and 8 degrees versus 4 degrees and -1 degrees for the non-injured trial. In the second phase, which is represented in green, from the force plate data, the authors describe a rapid lateral shift of the center of pressure. And then for the third phase in orange was where peak inversion and peak internal rotation occurred. So we can see peak inversion of the rear foot of 23 degrees and peak internal rotation of the foot of 46 degrees. And probably one of the most interesting features of this is we can see that peak inversion and peak internal rotation all occur before 200 milliseconds after foot strike. So these injuries are occurring with high angular velocities and high angular rotations in a quick period of time. I want to move now to these model-based image matching studies. So the paper by Mock describes both a contact injury and a non-contact injury, and then the paper by Fong describes 5 non-contact injuries. So this was the paper published by Mock and colleagues in American Journal of Sports Medicine, and they described 2 injuries, lateral ankle sprains, that occurred during the Beijing Olympics. The first occurred in a female high jump athlete. Okay, so we have the video sequence here of the injury happening, and we can see the large inverted position of the rear foot, and we can see that this happens in a very, very quick time frame. So with the model-based image matching analysis technique, the authors were able to reconstruct the skeletal kinematics. And this is the type of data that they're able to reproduce, so a skeletal model based on the camera data that they record. In the second injury, this occurred during field hockey, and this is a contact mechanism of injury. So we have the attacking player in yellow, the defending player in green. The defending player in green accidentally steps on the foot of the attacking player, causing an inversion injury. And again, we can see the time sequence here. This injury is occurring very, very quickly. And this is the skeletal model that they reconstructed to try and determine what were the associated injury kinematics. So here we have the position of plantar flexion of the ankle joint, the position of rear foot inversion, and the position of internal rotation of the foot. And what we can see is the 2 characteristic features is that there's a rapid increase in inversion in both instances, the high jump here in the solid black line and the field hockey injury in the dashed line, and the same here with the internal rotation of the foot. And what we can see is that that injury is happening very, very quickly. Again, peak inversion and peak internal rotation occurring within 200 milliseconds of foot strike. This was, again, the model-based image matching by Fong and colleagues. They published data on 5 ankle sprains that were recorded during tennis matches. So we can see the ankle sprains occurring here. And what we can see is the inversion, maximum or peak inversion of the rear foot, the sagittal plane position, plantar flexion or dorsiflexion, and the position of internal rotation of the foot. And one of the things that I was taught in physio school was that ankle joint inversion injuries are the result of plantar flexion or ankle joint sprains are the result of plantar flexion and inversion. But what we can see here is that the inversion mechanism can proceed irrespective of the sagittal plane motion. So there doesn't have to be associated ankle joint plantar flexion. So this shows the inversion position of each of those 5 injuries. And probably the most interesting thing is that at foot strike, each of the rear foot in the 5 cases was in a relative degree of inversion. So what does that mean? Well, if we think of the biomechanics of the subtalar joint and the rear foot, an inverted position of the rear foot will have the effect of shifting the subtalar joint axis in a lateral direction. As a consequence of that, we get an external inversion moment acting upon the rear foot, and this increases the likelihood or susceptibility to the development of an inversion ankle sprain. So, to summarize in terms of mechanisms of injury, non-contact injuries are more common than contact, and an inverted position of the ankle joint at initial contact is a particularly vulnerable position and has been identified as a key characteristic feature of lateral ankle sprain injury mechanisms. So I'm going to shift a little bit now, and what I want to do is introduce the dynamic systems theory approach to sensory motor control. So a healthy sensory motor system can accomplish a movement task in a number of ways, based upon its interaction with the task being performed and the environmental cues that it receives. So another way of articulating or talking about that is that the sensory motor system has a number of degrees of freedom which it can rely upon in order to accomplish a movement task. So what we propose is that lateral ankle joint injuries, or an ankle sprain, will increase the organismic constraints acting on the sensory motor system. That will have the effect of reducing its degrees of freedom and hence its ability to accomplish a movement goal. So this is a schematic outlining the sensory and mechanical properties of ankle joint ligaments. So we know that they have mechanical properties and we know that they have sensory properties. And from a mechanical perspective, the main role of ankle joint ligaments is to guide the normal joint range of motion through the expected physiological range of motion for that particular joint. From a sensory perspective, we know that ankle joint ligaments have projections to alpha motor neurons, they have projections to the gamma spindle system, and they also have projections to ascending pathways. So damage to ligaments are going to have mechanical consequences and sensory consequences, and that's going to potentially affect joint stability. So this is the ligamentous stability model proposed by Professor Jay Hurtle from University of Virginia, and Jay presented this 10 years ago at the International Ankle Symposium that we hosted in Dublin. So we have the inferior tib-fib joint, we have the talocrural joint, and we have the subtalar joint. And we know that those joints are supported by a number of ligaments. So we have the anterior-inferior tib-fib ligament, the anterior talofibular ligament, calcaneofibular ligament, we have lateral talocalcaneal, cervical ligament, interosseous ligament, and deltoid ligament. So what happens from a mechanical perspective when you get injury to those ligaments? Well, let's think of an injury to the anterior talofibular ligament. That will result in an inversion tilt of the talus and an inversion rotation of the talus. It will also potentially result in an anterior displacement of the talus as well. What about injury to the ATFL and CFL? Well, again, that causes an inversion tilt of the talus, an inversion rotation of the talus, an inversion tilt of the calcaneus, and an internal rotation tilt of the calcaneus. Isolated subtalar injury, so damage to the cervical and lateral talocalcaneal ligaments and the calcaneofibular ligament. Well, that causes an inversion tilt of the calcaneus and an internal rotation of the calcaneus. One of the other mechanical properties that people don't necessarily pay a lot of attention to is this mechanical property of hysteresis. So this suggests that with repetitive mechanical loading or high volume loading in a repetitive cycle, hysteresis develops. And effectively what happens is that the same applied load will cause a greater displacement of the ligament. That will result in the development of joint laxity and a potential increased joint or instability and propensity for the development of injury risk. So, mechanical properties of ligaments, alterations in these can have sensory consequences. So it can change sensory thresholds such as length and tension relationships, and that can subsequently result in the degradation of proprioception and kinesthetic perception. So threshold to detection of movement, joint position sense, and force sense. And as a result of that, we can get changes in movement positioning, inaccurate muscle activation patterns, and that can cause problems. So if we flip back here and we think about these three constructs, the organismic constraints reflect the structural integrity of a particular body part. The task is governed by the movement goal being performed, and then we have the external environmental cues. So what are the sensory motor consequences of acute lateral ankle sprain? Well, we are proposing that musculoskeletal injury will increase the organismic constraints acting upon the sensory motor system. That will have the effect of decreasing sensory motor control and may precipitate the development of a continuum of disability. So in order to understand whether there are sensory motor consequences of lateral ankle sprain injury, we undertook a study whereby we had first-time ankle sprainers. We prospectively evaluated them across 1 year. So they were all tested within 2 weeks of their injury, 6 months after injury, and 1 year following injury. And we were interested in the sensory motor consequences of acute lateral ankle sprain. And as such, we assessed participants during the performance of a number of tasks. So effectively what we were doing from a dynamic systems theory perspective, we were manipulating the task environment to see whether that resulted in differences in joint loads, movement mechanics. So we published a series of papers on this data. The tasks that were assessed: firstly, we had single limb stance. So we brought the subjects into our lab. They had a full lower limb kinematic setup. We analyzed their force plate data. They performed single limb stance on the injured side and non-injured side, and we also manipulated the task by getting them to perform it with eyes open and eyes closed. And what did we find? Well, the LAS group, so the lateral ankle sprain group, during the eyes closed condition, on both their injured and non-injured sides, they had decreased hip flexion, and they also had decreased complexity of their center of path pressure. So what does this mean, or how are we thinking about this? Well, when we take out the sensory cue of vision, what we're thinking is that the people with lateral ankle sprain injury couldn't shift from an ankle strategy of postural control to a hip strategy of postural control, which the control subjects could do. And most interesting, what we are seeing here again is bilateral consequences of a peripheral musculoskeletal condition. The second task that the subjects performed were the star excursion balance test. I'm sure people are familiar with this. There's 8 reach directions. We used the anterior, posterior medial, and posterior lateral reach directions. And what did we find? Well, again, when the subjects were performing these reaches on both the injured side and non-injured side, they were characterized by decreased reach distances achieved in the anterior, posterior medial, and posterior lateral directions. They also had decreased sagittal plane lower limb excursion for the hip, knee, and ankle joint. And then on the injured side, they had decreased complexity of their center of pressure path on the injured side only. We also had the subjects perform a single leg drop land, okay? And the LAS group were characterized by a decreased ground reaction force and also an increased hip flexed position. And what we're hypothesizing is that these were compensatory mechanisms for the lateral ankle sprain, with subjects trying to assume a protective position relative to the ankle joint. So they were landing in a more hip flex position in order to try and dissipate the loads, and they had a subsequently decreased vertical ground reaction force. So they weren't comfortable with taking weight through that injured ankle. In terms of the next paper, we looked at a drop vertical jump, and we know that the drop vertical jump has a number of phases. So they start atop a 40 centimeter box, they drop down, they land, they perform a maximum height vertical jump, and they land again. And what we found was that they had decreased rate of force development on the injured side when they had landed and were trying to push off for the maximum vertical jump. And then on the second landing phase, they had a decreased plantar flexed position of the ankle joint. And again, we felt that this was them adopting a protective mechanism in order to try and offload the ankle joint. And, okay. So, final paper that we published on these tasks at the 2-week time point was we found that the LAS group had a significantly increased inverted position of the ankle prior to and immediately after foot strike, and that was also associated with an increased external inversion moment. And we found earlier on when we were discussing the mechanisms of ankle joint injury that an increased inverted position of the foot at foot strike may have subsequent consequences in increasing your inversion injury risk. So what we think is, or proposing, that could this be beginning of a recursive cycle of injuries? And the injury that we're interested in is chronic ankle instability. And I published a paper back in 2010 with some colleagues from Dublin and colleagues from University of Sydney, where we looked at all the published literature in this area, and we looked to see what were the characteristic features of chronic ankle instability. And chronic ankle instability is characterized by repetitive episodes of giving way of the ankle joint and feelings of ankle joint instability. And that paper has subsequently been endorsed by the International Ankle Consortium in this tripart publication that I mentioned earlier on, JOSPT, BJSM, and Journal of Athletic Training. And it's a very interesting paper. If anybody doesn't know an awful lot about chronic ankle instability or wants to learn a little bit more, I would kind of direct you towards that as a seminal piece of work. So this is a proposed cascade of events by Dr. Patrick McKean and Dr. Eric Wickstrom. And what they're proposing is that lateral ankle sprain can lead to the development of chronic ankle instability, and that can subsequently lead to the development of post-traumatic ankle joint osteoarthritis. So ligament damage leads to impaired sensory pathways. What are those consequences? Well, due to the ligament damage, there's altered mechanical properties. There's altered joint arthrokinematics. We also have inhibition of appropriate spinal reflexes. We have the development of chronic ankle instability. That leads to altered joint loads, alterations in movement patterns, and then potentially the development of post-traumatic ankle joint osteoarthritis. So how do we determine whether someone has chronic ankle instability or not? And this was a book published last year, and we were asked to contribute to a chapter in terms of determining whether someone has chronic ankle instability or not. So we're proposing this series of questions. So a patient comes into you with an acute lateral ankle sprain. Question 1, have you previously sustained an acute lateral ankle sprain to the same ankle joint? If they say no, well, answer is easy. That's their first ever ankle joint sprain. If they say yes, we're proposing that you should ask them, when did the previously incurred ankle sprain occur? Okay, and there's 2 possible answers that we're looking for. Greater than 12 months ago or less than 12 months ago. And the answer to question 2 is going to combine with question 3 to give us a series of outcomes. So from question 3, we're interested in determining whether they are reporting any what we call residual symptoms. And those main residual symptoms are episodes of giving way of the ankle joint, a feeling that the ankle joint is unstable, what we call a feeling of instability, and then recurrent ankle sprains. So if we say no and combine that with 2A, whereby their previous ankle sprain occurred greater than 4 or 1 year ago, we call them a lateral ankle sprain coper. If they say no and we combine it with 2B, that their previous ankle sprain occurred less than 12 months ago, we say that this most recent episode is a recurrent sprain and that they have the risk of developing chronic ankle instability. If they say yes to question 3, and we combine it with 2B, so their previous ankle sprain was less than 12 months ago, again, we have this outcome that it's a recurrent ankle sprain and they have the risk of developing chronic ankle instability. Whereas if they say yes and their previous ankle sprain was greater than 12 months ago, because that's what we use for chronic ankle instability, that their previous ankle sprain should be greater than 1 year ago, we call this chronic ankle instability. And then you should look at a severity rating scale of chronic ankle instability. And the severity rating scale of chronic ankle instability that are recommended in the literature, there's 2 of them. First one is the Cumberland Ankle Instability Tool, or the CATE, published by Claire Hiller and colleagues from University of Sydney. And then the second one is the ID-FAI, which is identification of functional ankle instability, and that was produced by Dr. Carrie Doherty's group from University of Indiana. So, what happens after ankle joint injury? Well, you can become a coper or you can develop chronic ankle instability. So we have a paper just accepted in American Journal of Sports Medicine that shows following first ever ankle joint injury, first ever sprain, there's a 40% risk of developing chronic ankle instability after 1 year. So this is the paper here. It's actually the proof, and I had a good start to Sportskongres because when I got here on Tuesday, this was in my inbox. So always a nice start to the day for an academic paper ready to go into EPUB. So what we wanted to do then was see whether we could utilize any of the data we got from the 2-week time point evaluation and the 6-month time point evaluation to determine whether we could predict the risk of someone developing chronic ankle instability. Okay, so here we have again this, and at the 2-week time point, something interesting came out in our analysis. An inability to perform a drop land and a drop vertical jump within 2 weeks had a sensitivity of predicting chronic ankle instability of 0.83 and a specificity of 0.55. The associated positive likelihood ratio was 0.18. So what does that do to your risk of developing chronic ankle instability? It doesn't do an awful lot. It shifts your risk to around 50%. So you're probably saying, well, Eamonn, how did you determine that? Well, what we have here is Bayes nomogram, and what we have is our pretest probability of 40%. So we've established that the risk of developing chronic ankle instability after first-time ankle sprain is 40%. Using an inability to jump or drop land and drop vertical jump after 2 weeks, we had a positive likelihood ratio of 1.8, and using that line there, that brings our post-test probability to 50%. So that mightn't have an awful lot of clinical utility. Okay, there's a 50% chance of developing chronic ankle instability if within 2 weeks you can't perform a drop land or a drop vertical jump. So what about data we collected at 6 months? Well, we had the foot and ankle ability measure score, and that's a patient-reported outcome measure. And we found that a score of less than 89% on the FAM ADL, decreased reach distance on the posterior lateral direction of the SEBT. So if anybody doesn't know SEBT, I'm standing here, bilateral stance, okay? I'm testing the right leg, and the posterior lateral direction is me going back that way, okay? We use tapes on the ground, and we quantify how far they can reach. We divide the reach by leg length and multiply by 100 to get a percentage of leg length for their dynamic postural stability. And then decreased hip and knee sagittal plane range of motion whilst performing the SEBT in the posterior lateral reach direction. Now that had a sensitivity of 0.75, a specificity of 0.91, and a positive likelihood ratio of 0.8. So what did that do in terms of shifting your risk of developing chronic ankle instability? Well, it shifts it up towards 80%. So again, how did I get that? Well, we had our pre-test probability of 40%, positive likelihood ratio of 8, and that shifts us up to around 80%. Okay, so that certainly will have clinical utility. So if we go back here to the dynamic systems theory approach, okay, what we can see is that increased organismic constraints in the terms of musculoskeletal injury is going to have sensory motor consequences, and that's going to lead to decreased performance, because essentially people with chronic ankle instability are characterized by episodes of giving way of the ankle joint, and they're characterized by decreased functional performance. So it has been proposed that chronic ankle instability has sensory consequences and motor consequences. And this model was proposed by Dr. Patrick McKean at the 6th International Ankle Symposium in 2015. So we know that these patients are characterized by altered plantar sensation. They've deficits in joint position sense, so threshold to detection of movement, active and passive joint repositioning, and force sense deficits. They also have decreased range of motion. They have arthrogenic muscle inhibition. They've decreased balance deficits, and they've gait and landing alterations. So in order to comprehensively rehabilitate someone with chronic ankle instability, it's important to consider all of these aspects. So it's important to consider it as a true sensory motor problem. So in terms of the individual, we need to think about both the sensory and motor deficits. From a task perspective, we need to think about progressing tasks that shape sensory motor system strategies for movement goal execution. And then from the environment, we need to think about manipulating environmental cues for shaping the movement goal execution. So I'd like to finish off by saying, in my opinion, that lateral ankle sprains are not just a peripheral musculoskeletal pathology with only local consequences. So thank you for your attention, and I'm very happy to interact and answer any questions as appropriate.